Hello, my name is Professor Mike Parker. I'm a retired surgeon, having spent 50 years in the National Health Service in Great Britain as a general surgeon and latterly a laparoscopic colorectal surgeon, and with a lot of interest in adhesions over many, many years. And I've been asked to talk today on the financial burden of adhesions. Many years ago, in the 1990s, we started a study called the Surgical and Clinical Adhesions Research Panel Study. And this was to confirm the extent and the burden of the problem of adhesions. It was run by Professor Harold Ellis, who I'm delighted to say is still alive at the age of 97 and still very well, and a team of people who all were interested in adhesions as well. We looked at a large number of people, 54,000, and these were those who'd been operated on in Scotland and were on the National Health Database in Scotland, which is a very reliable database. Scotland has a very non-itinerant population. Only 1% will either migrate into or migrate from Scotland every year. And it's a very reputable database with 99% accuracy. So we decided to use that one. And by removing several of the categories, surgery within the previous 5 years and those with laparoscopic surgery, we ended up with 30,000 patients and grouped them into lower, upper abdominal and female reproductive. And you can see we had large numbers, and we followed those up for 10 years to see what happened to them in terms of adhesion obstruction. And out of the 30,000, you can see here there's those in those three groups. Those were the initial procedures in 1986, and then over the next 10 years, this was the number that were readmitted, but they were admitted on average 2.1 times. So about a third of the patients have one or more readmissions over a 10-year period. And it's equivalent effectively to the number of total hip replacements that we were doing at the time, or the number of coronary artery bypass grafts. So it's a huge number. And it doesn't go away over time. These were the figures over the 10-year period, showing that the first 18 months to 2 years is when the majority, or 50% of the readmissions occur. But it doesn't slow down. It continues over the next 10 years and will likely carry on, who knows, indefinitely thereafter. So in summary, we found that adhesions are associated with a very high risk of readmissions. Colorectal surgery was the greatest culprit, and it obviously increased the workload and had an impact on the health resources. And it's a problem that doesn't go away. This was confirmed the same year, actually, in David Beck's work, published in DCR, which showed nearly 20% readmitted with small bowel obstruction, and about 5% had adhesiolysis treatment, pretty similar to our results. And about 20.2% had subsequent colorectal surgery. The question then arose in the years that followed that, with the advent of laparoscopic surgery, as to whether, with surgical practices changing, was surgery becoming less adhesiogenic? So we repeated the study a few years later. And this basically showed us that having compared the results with the previous one, and having on this occasion taken into consideration laparoscopic and open surgery, would it make a big difference? Well, the answer was no. Adhesions continued to present a significant burden, and there wasn't any real reduction in this due to laparoscopic surgery. But to be fair, laparoscopic surgery was very much in its infancy in those days and probably hadn't taken much effect. Anyway, our conclusions at the time were, rather than look at any further for this, we just needed to try and devise some anti-adhesion strategies. However, over the next 20 years, laparoscopic surgery really did come to fruition. And the Dutch group in 2018 showed that it reduced adhesion formation by up to 50%. So under the leadership of Pepin Krellin from the Radboud Hospital in Holland, this group looked again at the Scottish National Database in 2022 and did exactly the same study with 16,500 patients to see if it had made a difference. And lo and behold, on this occasion, it did. You can see the figures here on these histograms from the overall and the open surgery, and then compare them with the laparoscopic, and you can see there's a significant reduction in reoperations. And this is shown even better on this graph, which shows you these are the open surgery group, and this is the laparoscopic group. And you can see that over time, it continues to be a big difference between the two in the number of readmissions and the number of operations that they're undergoing. Highly significant results. So laparoscopic surgery does make a big difference. So much so that in open colorectal surgery, you can expect a third of patients to come in to be readmitted with adhesion obstruction. But in laparoscopic, it's a quarter. So although it's reduced, there is still a substantial effect even after laparoscopic surgery. And so using those figures, you can work out the costs of adhesion obstruction and what the adhesions cost the country. Dominguez and I looked at two hospitals in the United Kingdom, Colchester and Dartford, roughly the same size, 250,000, 300,000 catchment, that sort of size. And we looked at the breakdown costs of surgical admissions treated operatively and non-operatively. Big figures, you can work out in a moment, you'll see what they are. But what we found was that in a hospital serving about 250,000 people, it accounted for 287 bed days per year, took up 10 extra emergency laparotomies, occupying 2% of the total beds. And effectively, the operating room was blocked for over 2 days every year, just with dealing with adhesions. That's 24 hours a day for 2 days. This is the breakdown of the figures. You've no need to read all the figures. They're obviously very complicated. But the bottom line here is that it costs us just under £5,000 to operate on somebody with adhesions and £1,500 to treat them non-operatively, with a median length of stay of 16 days and 7 days respectively. And that was published in the Annals of the Royal College of Surgeons. So if we look at the actual costs, you can see the costs in 2001 were as shown in pounds sterling. But of course, things have changed a little bit in the last 20 years. And now taking the index from the Office of National Statistics, the increase in costs, it's about 2.06 in the UK, slightly less in the United States, about 1.8. But if you multiply that by 2.06, you can see the costs, because of inflation, have gone up to £8,500 and just under £3,000 for non-operative costs. And so in the UK, with a population of 67.3 million, we know that there's just under 10,000 admissions for small bowel obstruction, of which just over half are due to adhesions. And so that's the total number of admissions every year. And we can work out that the costs in this country, in the United Kingdom, each year are about £28.3 million, $34.4 million roughly. In Finland, they've also looked at this some years ago. Similar sort of figures, actually, for a population of about 5 million people. 118 inpatient days in total. These are national figures, so they're looking at the whole area now. Mean length of stay, 11 days, compared with 4 days for non-operative, not dissimilar to ours. And a bed stay of about 3 surgical beds per year and 11 days of theatre time, more than ours, but those were based on daytime operating figures. So their figures showed the impact on the Finnish health system at population level was as follows: 124 days of operating time and an estimated cost of about £2 million, just over 3 million euros, which is about $3 million US as well. And it's the equivalent to the cost of treating all their varicose veins or all their rectal cancers or all their gastric cancers. So again, in cost terms, it's huge. In Sweden, they looked at this as well in a population slightly bigger, 7 million. And their figures showed that they had an estimated direct cost of patient management of about 13 million US or 10.5 million euros. And that didn't include indirect costs such as the cost of sick leave and travel and so on. When we come to the United States, Everson in 1997 published the figures for adhesion problems in the United States as 1.3 billion per year in 1997. So extrapolating that to today's figures using 1.8 as the inflation index, you can see it's now about $2.4 billion a year in the US, which is massive. The only solutions really I see at the moment are looking not at the operative technique so much, but looking for adhesion prevention strategies. And indeed, that was the case many years ago in the United Kingdom when this lady who'd had adhesion problems and had not been treated with an adhesion prevention device or drug at the time of her operation had this piece published in the newspapers saying that £50, which was the cost on average of what they needed at the time to prevent adhesions, or those that were thought to prevent adhesions, would have stopped her suffering. Thank you very much indeed.